Well, good morning, vast crowds of Washington, D.C. So thank all of you for getting up so early in the morning. Quick poll, who's had coffee so far? Oh, there we go. Awesome. So hopefully we'll be able to learn. Only a couple of us have had coffee this morning, so you'll sort of see differences among the panelists of who's more awake and who's not. I'm Harry Greenspun. I'm the Senior Advisor for Healthcare Transformation Technology at the Deloitte Center for Health Solutions. It is a privilege to be here and to have you listen to some of what's going on in the mHealth world. We have the exciting title, The Future is Now. We had to have an exclamation point because it was, again, an early talk. But we are actually going to talk about some exciting stuff today. And I've got a fantastic group of panelists who are joining me. We actually seated them in the order that you see them on the screen to make it easy for you to figure out who's saying what. We want to keep this as conversation as possible. So if you have a question, feel free to jump up to the mic and yell out and call out one of our panelists as you go. So I thought, since it is early and we need to entertain you a little bit, I'm going to have each of the panelists introduce themselves, but more importantly, not only say who they are and what they do, but justify why it was worth getting up so early to hear them on this panel. And Chris, I'll start with you.
I'm Chris Brancato. I'm a specialist leader for Deloitte in the federal health practice. I serve a number of clients, mainly in the Office of the National Coordinator for the last 4.5 years. What got me up this early? I'm on the deck at 0500 every day, so I was ready to go.
There we go. But Chris Chris again does much of our work with the Office of the National Coordinator, and I think can provide some interesting views in that regard. And for Brian, I feel especially bad because Brian, of course, is on Pacific time. So let's see how coherent Brian can be.
Yes, thank you. I'm Brian Gardner. I lead the Kaiser Permanente Mobility Center of Excellence. Our group is responsible for enabling mobile technologies for Kaiser at large. We do consumer portfolio that serves our 9 million members. We have a clinician and caregiver portfolio for our physicians as well as our 180,000 employees. It is early. It's about 3 in the morning or 4 in the morning for me. So I actually wanted to see who was going to be here this early. So that's one of the reasons I'm here. So glad to see that we have everybody kind of dispersed across the large room we're in now.
There we go. So we're pulling them in as we go. Julia, so Julia's a psychologist, which was very helpful for us as we try to understand what we're going to say today. But Julia, introduce yourself.
Hi, I'm Julia Hoffman. I am coming from right next door, so in Menlo Park, California, in the Silicon Valley. I'm the lead for mobile for mental health for the U.S. Department of Veterans Affairs. And I recently moved over from being the mobile lead for the Department of Defense's National Center for Telehealth and Technology, where I'm still a faculty affiliate. I woke up this morning because it's my second day without my infant son, and I kind of missed getting up at the crack of dawn. So thank you all for providing this opportunity.
Good morning. I'm Carrie McDermott. I'm the Senior Director of Healthcare Technology Policy for the West Health Institute. And the Institute is part of a broader family called West Health that has a medical research organization, a policy center, an investment fund, and an incubator that are all working together to lower the cost of health care. And we're really about turning health care on its head such that we're not organized around the clinician and where the clinician is located and when the clinician is available, but really being about the individual so that we're giving patients the right care at the right time wherever they are. And of course, mobile certainly plays into that. And I'm hoping that from my former role as the healthcare director for the Federal Communication Commission, I'll be able to share some more federal policy insights with you, having worked with the FCC and the FDA specifically and extensively on how do we bring emerging wireless medical technologies more quickly to market.
As Carrie has the distinction of speaking not only in the first panel of the day, but also the last panel of the day. So she will have a long day here. And Kelvin?
Okay, good morning, everyone, and thanks for being here so early this morning. For me, by way of background, I'm also a former Marine, so I am used to getting up before the sun comes up in the morning. But thank you for being here. My role, I lead all of our federal health care work at Deloitte. So with that, and that includes the VA, all of our military health clients, and all of our federal health and human services clients. So from my perspective, the value that I bring here this morning is I get to see a panoramic of what our clients are asking for, the kinds of challenges that they are facing when they look at things like innovation, including innovation in mobile health. So hopefully I'll be able to share some perspectives for you as to what I see has changed in the landscape of what our clients ask for and how we serve them in helping innovate in healthcare.
Fantastic. Well, we're going to sort of jump around in the timeline of the present, the past, and the future. I want to talk about the present for a second. And Brian, I'll start with you. Kaiser has had a long history of doing things in mobile, but actually is in the process of unleashing a whole bunch of new mobile apps. So let's talk a bit about what drove that and where you're trying to go with it.
Sure. We've actually been looking at mobile traffic to our online KP.org website for about 2 years. And in early 2009, when we first started looking at it, it was about 2% traffic to that website. Our website is currently, for our members, we have over 4 million members that are registered to use that website, and access to that medical record is something that they're really doing on a regular basis. That traffic kind of trended at a really high rate. At the end of last year, it was upwards of 14%, at 17% now. So that kind of sparked us of this is how people are starting to engage with their doctors, make their appointments, refill their prescriptions, and things like that. So we've actually broken out our portfolio for the consumer audience into flagship applications and then some supplemental preventive type applications for management. So.
Fantastic. And Julia, the VA has done a lot of interesting things in health IT and other technologies, but mental health has actually been one of the earliest adopters of mobile. Talk a bit about that.
Well, I think our justification is maybe a little bit different than medical health. So when you look at the literature, about 40% of veterans who need help with mental health issues, especially after Operation Iraqi Freedom and Operation Enduring Freedom, which are Iraq and Afghanistan conflicts, only about 40% of the people who need help get help. So when you look at why they don't get help, there's two main reasons. Number one is stigma, some of which is real, and they're afraid of loss of position, loss of career, and there unfortunately can be those real effects as much as we try to combat them. And some is imagined. And the second reason is logistics. So 70% of veterans who return from the current conflicts are going back to rural areas, what we consider rural areas. So even with outlying clinics, we have a hard time providing care. And with mental health treatment, you're not just showing up one time to the doctor, you have to show up again and again and again. It's a relatively high intensity treatment. So what we need to do is provide stigma-free alternatives to care, where mobile makes a lot of sense. We can create anonymous tools, not necessarily that replace, not at all, that replace therapists, but or docs, but that can supplement and that can provide someone something in the place of nothing, and provide them care where they are, when they need it, without all of the hassle of needing to get into clinics, especially for young people who are busy and have families and jobs.
And Carrie, in your prior role at the FCC, you obviously dealt with rural broadband issues, and I think that Julia brings up is the difficulties of reaching people where they are. Talk a bit about some of the challenges that the nation faces around that.
Oh, sure. So we know that connectivity is a big issue, especially wireless connectivity, and that's one of the best ways of reaching folks in rural areas. Next week on the 12th, the FCC is actually going to be announcing its reforms to the rural health care program, and they've taken a couple other steps this year. One was setting up a mobility fund, so they're trying to get the wireless carriers to actually invest in these underserved areas. And the FCC's role in mobile health is managing spectrum, which is a finite resource, and that's the airwaves. These are the highways that make all of mobile work. Manufacturers are coming up with the devices; those are the cars, and then the FDA is making sure that all the cars are functioning properly. And so when they tie this together, it's really important that they understand what parts of the airway are suited to different healthcare needs, and the FCC is taking a look at that right now.
And so, Kelvin, along those lines, sort of the government's role in the government has sort of different ways of looking at innovation. Talk about sort of your experience in helping government agencies with sort of becoming more innovative and doing more interesting things.
Yeah. So one of the things that we've seen changes is instead of our clients asking for solutions, i.e. things that we have done before for other clients, either in the federal or the commercial space, one of the things that they're asking for is ideas, not just solutions. They're looking for ways to change the way they think about how they serve the public. So one of the things that we have found to be successful is to bring them to a place, many times with their data, to let them experiment, to let them brainstorm together, to let them ideate or generate ideas. And a lot of what we are seeing now is that is very exciting to them. We had one client at HHS that spoke to us and said that what we need these days is someone that can give us profound thinking, because the technology world has just changed everything, and it's changing so fast we can't keep up. So we can't just come up with solutions. We have to come up with ways of thinking about the problems of the day and how we serve the public, how we connect with the public, and how we provide health care to the public. So this whole idea about disruptive innovation and how we think about problems is something that they are hungry for, and they're looking for ideas from not just other parts of the United States. They're also looking for ideas from other countries and how they handle things. So, you know, that's what we're seeing as a trend.
Yeah. So, Chris, innovation sounds awesome, but not so easy to actually to both regulate and administer. And the Office of National Coordinator has been trying to deal with these sort of issues. What's going on there that's helping either promote or making this more challenging?
Well, specifically to ONC, ONC has adopted the path forward to make sure that they can coordinate with other federal agencies, some who are doing mobile technology already. And then how do they bring that into the fold under meaningful use? So what people may not realize is that the HITECH Act actually gives ONC some broad powers well beyond the EHR technology that you see the focus today. It can encompass any mobile technology or any technology that might be part of an EHR, but not necessarily within the current definition of an EHR. So that may be medical devices as well. So the general strategy is to coordinate with other federal agencies to set appropriate policy. The biggest concern right now at the Office of the National Coordinator is privacy and security of these devices and the mechanics of them. So this may be a little nugget for you, is ONC strategy is based on how do they use mobile technology to address the 11 national health priorities.
And then I just wanted to jump in with that and note that another reason that innovation in mobile health in particular can be so difficult is a lack of wireless test beds. So if you're a large manufacturer, you have a device maker or whatnot, you have the resources available to test everything and know that you are functioning properly from, an RF perspective and a device perspective. But if you're a small startup, you don't have those resources. And that's another area that the federal government has been looking at. So this year the FCC has been working on changing some of its experimental licensing rules so that they could actually set up wireless test beds or enable wireless test beds, some of which would be specifically for medical purposes. And we note that how to manage wireless is of interest across D.C. If anyone caught the news yesterday, Representative Mike Honda from California actually proposed legislation that would establish an Office of Wireless Health within the FDA. And the purpose there would be to advance coordination efforts both within the FDA's own efforts and across agencies, and then set up programs to help developers and small manufacturers actually be able to advance these technologies. So it is a topic that policymakers are paying a lot of attention to. That might be good news or bad news, but it's definitely on the radar.
And Brian, you said it made it sound so easy, maybe because you talk so quickly. We talked about a lot of challenges, and yet, you being able to accomplish some things. What were some of the biggest barriers that Kaiser faced getting these off the ground?
I would say a lot of them were internally trying to get the folks inside of our organization convinced that mobile health was where our members were going, and not necessarily letting go of what we had already done from an online perspective, but basically leveraging all of that. So I would say the barriers were normally within our organization around sponsorship and governance and things around, we're a large organization with a lot of really smart people that have a lot of really good ideas that want to get things done really quickly. And having a way to govern and understand what we should do first and what we should do next and who it's going to benefit is a challenge that I think most large organizations probably have. We've established some governance, at least in the consumer portfolio space. That's for our members and how they're going to access their EHR from a mobile device, which we're doing now. When we get into the clinician space, there's a large number of physicians that we work with, and getting them to articulate what it is that they need right away versus building out that roadmap and a product portfolio is something that we're working on now. So I think the barrier is inside, not necessarily on the outside.
Okay. And Julie, the VA has a long history of being innovative in IT, and great to see Dr. Kolodner in the audience here. How do things go at the VA? I mean, the VA was an early adopter of IT. Was mobile different?
I don't think so. I think we have been managing some of the governance processes, setting up certifications. I think that we have the opportunity, everyone sees this as a great opportunity to not remake the mistakes that have been made with web or in other kind of contexts where we have too heavy of a process, too much bureaucracy. And so this is an opportunity to devise a lightweight process. At the same time, patient safety comes first. We need to ensure that the VA brand is safe and that we're not doing anything that's unreasonable. We remember that VA has thousands of physicians, all of whom have great ideas and all of whom want to build their mobile app for their clinic. So we need to ensure that all of those are, mission consistent at least, and that they have some sort of branding oversight. But it's really, we've had a great opportunity to move relatively quickly and to start with a big, clear blue open sky. So.
Okay. Kevin, I'll jump to you for a second. Talk about, everyone's mentioned this process of governance and decision-making processes. With innovation being, exciting and interesting, people can get swept up in what's fun, what's new, what's different. How do people make rational decisions about where to make their investment in innovation?
Yeah, it's a very good question. It's a hard one because what we're talking about is innovation of the disruptive type. We're not just talking about replacing old technology with new technology that changes the value proposition. If you really think about it, these decisions also are talking about changing infrastructure. So when you think about what we have with iPads and iPhones and these mobile devices, they haven't just changed the value proposition from a technology standpoint. They've replaced or negated the need for infrastructure, and it's a different type of infrastructure. So, for example, if you have one of these, instead of having to go to the bookstore and drive 5 or 10 miles away to get a bookstore, if I gave you a book right now that I recommended, you could have it in 5 seconds. That brick and mortar is no longer needed. So when you make decisions about investments, you're not just making a decision about value, you're making a decision about what that technology can do from an infrastructure standpoint. Finally, when we make decisions and we help clients make decisions about investments, you always get back to value. And in this case, value from the perspective of a customer or a patient. And when it comes to adopting this type of technology, that's a matter of perception, that's a matter of individual preference. So, for example, I think we could all agree that if we had an application, and I had a discussion with one of our colleagues from the National Health Service last week, and they were talking about how do you incentivize higher performance in the NHS from a client centricity or customer centricity standpoint, and they're looking at the use of social media. So you walk into a hospital with a device like this that has location services, so you know which hospital you're in. The device will tell you what hospital you're in, and you can use social media to actually record your experience in that hospital. So they're looking at things like that. So imagine the decision making that would go into trying to put in an infrastructure or a capability that would give the patient the ability to real-time measure performance in a collective way of a hospital system.
And so, Kevin, you talk about value, and Carrie, I have been famously quoted for saying, just because I have a fitness app on my phone does not make me an athlete. One of the questions arises, is this going to make a difference, and how are people going about figuring out whether that makes sense or not?
Oh, that was to me. I didn't have the coffee. I missed Minnie. No, I think it will make a difference. So, again, where we come from is all about lowering the cost of health care. And you think about the power of mobile, it's about changing how you engage in managing your own health, whether it's being preventive to prevent the onset of conditions, or if you do have a chronic condition, it can make your care and management much more convenient and in some ways more private. There's a little bit of irony when we talk about the privacy concerns, because we of course want the secure transmission of our data and for that not to end up in the wrong hands. But if I have something wrong with me, it's much more discreet to do something on my phone than to have, I've got to walk into a clinic somewhere, or I've got to go do some kind of test. So I get a little more privacy in continuously managing my condition. And on chronic disease, that really requires real-time continuous monitoring. The whole point about these mobile apps is that you can have devices and sensors that are going to detect problems before you're symptomatic, and that way you can actually avert going into crisis and rescue mode. So I think it will make a difference, and when we look at the spectrum of consumer uses, the people who have the Fitbits and the Fuel Bands versus actually for medical devices, for more chronic conditions, I think we're seeing more activity at the ends of the barbell, if you will, and it will start to converge more towards the mainstream. But at the end of the day, as we heard from the speakers yesterday, this is all about getting connected and sharing in a secure manner such that your health care becomes more convenient.
So some of your thoughts. Julia?
Oh, I'm sorry. I guess I also...
We'll just keep going up and down. That'll make it easy. I don't have to call people out specifically.
This whole side of the table is uncaffeinated. I guess I'll go out on a limb and say something controversial-ish, because it's early and maybe none of you will remember it. I feel as a mental health, with my training in mental health, that I'm very skeptical of the number of tools that I see at all of the 2.0 and innovation, et cetera, conferences that are for tracking calories, doing exercise, all of the kind of, monitor your heart rate, all of the things that I think are relatively low-hanging fruit. It's not that those things do not significantly, probably more significantly than most things, impact your health overall, and even impact your mental health. But that I think that most of the hard challenges are yet to come. So I actually do have a weight loss app on my iPhone, and I guarantee it's helped me lose 0 weight. And part of that is because I have a baby and I'm tired and I want to just eat away my tiredness, which makes sense at certain times. But the other reason is because it's not inherently motivational, right? It's motivational for the first couple of days or weeks that you have it, because it provides you a cue. It provides you an interesting cue that might be novel. But after that time, what you need is sustained motivation to do something. And any physician or any kind of medical practitioner worth their salt knows that actually motivating a patient to put on their sneakers and go out for a walk is the hardest thing that you can do on an ongoing basis. You can get them to do it once, especially if you take their hand and go with them, but you can't necessarily get them to keep doing it. So my question is, where's the psychological science here? And not just for addressing mental health problems, not just for managing the huge numbers of the huge amount of depression in this country and the huge amounts of all, which we're medicating with some huge percentage of our population taking SSRIs.
And for the non-medical in the audience, SSRIs being, of course,
antidepressants, the regular ones like Zoloft and Prozac, all the ones you've heard of. But what are we doing to engage all of our understanding of motivation, of self-efficacy theory, of all of the tools that psychological sciences have to actually get people to do stuff over the long run, we think maybe?
Yeah, carry the point.
Yeah, I just wanted to jump in there and say that Julia is highlighting a really important challenge in this space, which is where is the scientific evidence? And there are different stages of research, and NIH has been doing a lot of work in this area, and this year they actually went down the pathway of investigating establishing a public-private partnership to build the scientific evidence base around mobile devices and applications. And we've seen other private efforts, like groups like Haptique, thinking how do we evaluate so that, we're investing money in these things. Do they do what we expect them to do? And that's an important question, I think, on the business angle. Until we're able to have some more validation and proof there, it's harder to prove the value case.
And Brian, Kaiser's taken the big jump. If you look at a lot of innovation, and as Julia mentioned, you go to Health 2.0, those kind of sessions, people talk, there's a lot of cool stuff out there. I can scan my food, I can try, I've got a fuel band on to shame me into getting exercise from day to day, or at least when I fly in an airplane, just to do this a lot, to see if I get credit for that. But, it's different saying that we're going to try to improve someone's health or fitness versus tie it directly back into a healthcare provider. Talk about that.
That's an interesting question. I want to touch on one thing. I think it's true about the evidence and the results of the motivation, and are they actually changing people's behavior. I think at least from an engagement perspective, it's created an awareness. I know that I have my fuel band. I've had it for about 6 or 7 months. I do start taking the stairs. If I look at my number or my color is too red, I do have a goal. I want to get it to green, and it's not necessarily making me more active, but I think at least it's a constant reminder. So I think that's there. I think one of the things that we're looking at is how do we start making these everyday applications that people interact with on a regular basis part of sort of your health conversation. So you have your EMR, your EHR, and your personal health record. Then you actually have your health plan data. How do you sort of combine all of that together to give you an overview of how you are physically and your health? So we haven't solved the problem. We've obviously asked the question. We're trying to understand how do we actually get access to all of this data and combine it all together. We talk to our physicians often and say, well, how are you going to use this if we bombard you with data, especially like exercise data or blood data? What of this is important? And we don't know that yet. So, at least we're asking the questions and having the conversations.
So, Chris, of course, data is huge now, and trying to understand, how is this data going to help us?
Well, I'll use a personal example. I have hereditary diabetes, and I use my mobile technology a lot to the point where I was able to knock 2 full points off my hemoglobin A1C, which allowed me to be unmedicated for a long time.
We should give Chris a round of applause for that. There we go. Look at that.
Thank you.
We're going to move more into sort of daytime television as we kind of a little bit later.
Now there was one other part of this. Because I was able to bring data from my glucometer to other apps on my phone, more specifically, I was able to continue to calculate what my A1C would be interstitially between my 3-month blood draws. I was able to detect an error in the A1C machine in my provider's office. It was off almost a full point. And my A1C calculations have proven to be 0.5 within the tolerance of what the machine is reporting. So I know pretty quickly if they're making a mistake or my glucometer is making a mistake. Now, admittedly, I'm a clinician nerd, but I think that's just a perfect example of where we could start using, or many of you are, mobile technologies to empower a patient to kind of seize the day with their own health data.
And we've talked about personal health records, electronic health records, moving data around, and maybe keep going back in this direction again about that. Where are we going to drive value out of the data that we're getting from our devices and from other sort of patient-reported information?
I don't think I have an immediate response to that one. Maybe I've only had half my coffee.
Well, I guess the question I'm asking is, as we start getting more data in the long term, where do we see the value of mixing, data from clinicians, data from our phones, data from remote monitoring, data from our buying habits, all the kind of stuff we're lumping into our larger analytics profile. Kelvin, I see you nodding down there.
So I think I'll answer to start out with a question, and this gets into interoperability. So we've used examples of personal health devices and those types of things. I use them too. I've got a Nike watch that monitors my heart rate, throws it up to a website. But what I think we need more of is we need to be able to connect these data. So my data goes up to a Nike website, but it does not connect at all to anything else. And if I could combine the preventative health information with results, i.e., am I healthier or not, because of what I'm doing in a preventative way, I think that would, for me personally, that would be of more value. But we can't do that now because I don't see the interoperability of all of these capabilities, all these apps that are coming out there. I don't see us being able to connect the data so that we can put the analytics on it that would provide it. And I go back to something I think we've mentioned before. I think value is a matter of perspective. It's a matter of an individual taste. So, for example, these devices give us conveniences. The convenience of being able, is the example I gave earlier, to buy a book in 3 seconds versus go to a brick and mortar place. But for some people, that's not of value. That's not of value to a person that really enjoys just turning a page in a book the old-fashioned way. So I think we really need to think about these things, the interoperability, and can we connect these data so that we can really provide value based upon what a person, individual values. And I think we have to recognize the fact that what seems to be valuable, like convenience, doesn't really mean that much to some people.
And Carrie, you've done a lot of work in device interoperability issues, and this is a big challenge.
No, absolutely. I want to go back to your data question for a minute, though,
Certainly.
if I may. And I think, when we go grocery shopping, it's amazing that we can leave the store with the right coupons that are tailored to us. So the more data we can know about ourselves as individuals and ourselves as a population, we can start to analyze that and just better tailor care. So we hear a lot of buzz about personalized medicine and the move in that direction. But I think there really is value in that. A good recent example is some of the efforts out of Dr. Patrick Soon-Shiong, who is an LA billionaire who has a company called NantWorks, and there's a subsidiary within it called mHealth. And what they have done is built the first genetic supercomputing platform to help analyze the cancer genome. And so they have now, I think, over 8,000 oncologists at 2,000 practices around the country connected, such that when a patient walks in, they can have their specific cancer analyzed and know before they start treatment what the right protocol would be for them. And that seems like such a no-brainer. Of course you should know the proper treatment before you start, but really up until now the computing platform and power was not available, so we weren't able to do that. And think of, you're suffering from cancer and you're getting, hit and miss, hit and miss, hit and miss. That's not the way you want to be treated. And so now we can have this change leaps and bounds, which results in a better patient experience and certainly a better cost profile for everyone involved. And then to harken back to interoperability, we spend a lot of time working on this as an institute, and the FDA has been working with a group called the MDICC, which is a Medical Device Interoperability Coordinating Council. And this has been a forum for all the large device manufacturers and standards development organizations to come together to figure out how do we drive forward device interoperability. And, it's interesting when you have conversations with the device manufacturers, they pretty much say either, well, our devices are already interoperable, or our customers aren't demanding it. And then, put them in the room with the health system and they're going, no, our stuff does not talk to each other. It's not interoperable. So we have a huge disconnect. And the problem here is that this is not an issue that the free market is incented to solve. The lack of interoperability, has these proprietary silos. Business models are under threat. And so as we work forward, I think we have to pose the honest question of, will we ever attain interoperability? And it's a push-pull. I think there's a role for the government to start to make mandates, but that's tricky because you would have to know exactly what to ask for. And we certainly don't want to get into the business of the government picking technology winners and losers. And then, I guess that's the push. And then the pull is coming from the buyers. Health systems need to be able to band together and really coalesce their purchasing power to make a difference. Providers. Kaiser is a big institution, but unless you can actually pull together 25, 30%, whatever the magic number is, of a device maker's market share, it's going to be very difficult to effect that change. And it's fun to talk about it at a high level. As soon as we start getting into the technical nitty-gritty, it gets messy quickly. I feel like I'm all bad news this morning. Like, there's no scientific evidence base, there's no interoperability, but at least we've identified the challenges, and there are forums. And I'll just throw out there that yesterday the FDA announced a new public-private partnership. This is with the MDIC, Medical Device Innovation Consortium. and they are looking at how to improve regulatory science. Their initial focus is going to be on computational models, but if you think about how devices are built and tested, it would be great if both the people creating the devices and then the people evaluating those devices were using the same tools. And that would do a lot to speed the pathway. So that's a big effort that's just been launched, and I think both the agency and the device community are excited about that development.
Other thoughts? I see a lot of heads nodding there. Chris? Or Julie, go ahead. Yeah, Julie.
I guess I would say I had not heard about the cancer genome work. It's incredibly interesting, and of course it makes a ton of sense. If you add a person's visa purchases on top of that genome, how much additional do you get? My guess is almost nothing, right? So we get sort of data happy because we can have the data all of a sudden, and so I think we're in an expansive phase where because we can, we're going to try and see sort of statistically what falls out. But it points to, I think, one of just another challenge, which is making meaningful sense of, a massive amount of data and understanding how not to just go on a statistical fishing expedition, but instead to identify real meaningful trends. And then beyond that, because I think there are tons of experts in analytics who can do an incredible job with figuring out the kind of statistical trends that we're looking for, but then representing that to physicians and providers in a way that's actually meaningful is the next step. So all of the visualization tools, all of the ways of culling that data so that a person can actually sit down in a 15-minute session with a patient and make some relevant clinical intervention on the basis of data is the next sort of frontier that I think is we've only touched the surface of so far.
Yeah. Chris?
Yeah, so I think there are some interesting challenges we see across a wide spectrum, as Kelvin said, and a lot of challenges center around a lack of vision about what they want to do mobily. For example, we'll walk into a client and they have absolutely no concept of what they want their mobile initiatives to do other than they need to go mobile. And that's a dangerous place to be because you'll start to invest a lot of capital into developing a mobile platform that is just unusable to the stakeholder and clinically irrelevant to the clinician. And I think before anybody decides to go down that path and develop a mobile app, you really have to focus on just exactly where the values lie, whether it's a patient or whether it's a clinician or both. You can't build an app that's trying to serve both masters generally.
Interesting. I guess speak out, and Brian, I'll go back to you, give you a meatier question to work on this time. But, excuse me. A lot of what enterprise are doing is using mobile to do what they do better. What are some of the things that Kaiser wants to do differently with mobile that they hadn't been able to do before?
We look at, so I think mobile is, speaking of data and connection, it's a connector of around like 4 sites of care. There's the in-hospital staff beds, those don't go away. There's the medical office buildings and clinics, those don't go away. Home health care is becoming more pervasive, and that's a third side of care. And then the virtual care is really the mobile enablement piece of it. We look at technology as connecting all of those sites of care. And the ability, from our strategy perspective, is yes, we do want apps. We do see member engagement. We do see clinicians asking for mobile devices in order to practice better, not be behind a computer screen, but actually be engaged with the patient. So we look at mobile as an empowerment and an engagement tool, and it's something that is just kind of coming, and we want to take advantage of it in order to connect those 4 sites of care. I mean, it's your health doesn't just happen at the clinic. Or when you go in for your office visit. It happens every day. It happens at work. It happens, at the park. It happens at home. So I think mobile technology and the apps is really the connector of all of that. And what we started with was we said we had a pretty powerful platform online, and obviously that's what people interact with us most often on. That is sort of our first step into that. What's coming next is one of the reasons why we're here is how can we take that next phase and take that next step to understand data, where does it live, how does it become part of your record, how does that become part of the conversation with your doctor? Because when I go see the doctor, I may just be going for one particular reason and talk only about that during that 15 minutes. But, I may have just had for the last 6 months done a pattern of behavior that I'm not aware of. But maybe there's something on my app or my phone that I've actually been sort of trending that data, whether it's a social app, whether it's a check-in at certain places I shouldn't be going or something like that, that you can actually start mining that data and saying, you know what, your behavior actually isn't what you're telling me it is. So, it's really around back to those 4 sites of care, great technology in each one, and then the mobile technology actually connecting all of those.
Julie, how about you?
Well, with mental health, we have a lot of really interesting things that we can do. I think most people know that suicide is a huge problem for our population, for veterans and service members. And suicide, unfortunately, is very hard to touch clinically because the people who actually complete suicide are different than the people who attempt suicide scientifically. And suicide itself, in spite of the large numbers of people, of veterans and service members who do complete, it's still a relatively low base rate activity. So it's hard to identify statistical trends that are going to lead people there and to catch people before they get there. Mobile surveillance and sensing allows us to have unprecedented data to try and identify those individuals before anything happens. It also helps us to take some of the burden off of the system and providers for trying to increase problem recognition. So with mental health, a lot of the challenges are around people seeing that they actually have a problem. Everyone who comes back from deployment is changed forever. Everyone who comes back, not necessarily for the worse, everyone who comes back from deployment has some number of struggles in reintegration. So how do you differentiate between that and a real episode of some significant mental health disorder? We can use these apps for increased problem recognition and to help people who may not be necessarily ready to make that phone call or make that office visit to identify that they're actually having a problem. And then finally, we can help people move at any stage of change. So if you look at everything from pre-contemplation through the action stage of treatment all the way through relapse prevention, we can build apps that assist people at every single stage so that even when they don't need the active treatment of a provider, that they can still be using the apps to maintain their treatment gains, or they can be using the apps to move them into needed care. So I think we have a lot of really novel opportunities and that especially impact mental health, but that can be used across the spectrum.
Yeah. Carrie.
I actually had a question for 2 panelists, if that's okay.
Certainly.
I would like to be the moderator now. No, just kidding. Role change. No. But so for Brian and Julia, a lot of the talk is about the mobile apps themselves, and I was just wondering what your thoughts are as far as devices versus apps as the mobile solution going forward, in terms of getting the monitoring devices in combination with apps. And then the other question, Brian, you triggered something for me that I thought was really interesting around validating patient patterns. And how do we think, we never lie to our doctors, of course. So how do we think people will feel when they've got kind of more, let's call it, oversight of their health?
In their pocket.
Yeah, exactly. Are they going to start cheating, or are they going to stop using these things because they feel too watched? I was just wondering your, reactions to those things. Or
Well,
sense of that.
I think the last piece, I think it's about permission. So, that's one thing. It's still my data, right? And I need to give my doctor permission to see it. I think because I have it and I can connect it to my medical record doesn't mean it should be done automatically. So I think that's my short answer to that one. Apps and devices, apps and medical devices, it seems like all medical devices now come with a supplementary app. We're not really looking at medical devices and medical device manufacturers. I think we're looking at the market and seeing how that's evolving. Apps is something that we're actually can control and customize and build our own. So that's why our focus is more on apps right now, at least from my perspective, and that's what my group does. And I don't really have the big answer for where are we with, our own Kaiser device. I don't have the answer to that one.
We were initially scared off of devices because of impending FDA regulation that then didn't materialize in the way that we thought it was going to. So our conservative approach there, I think we're going to be revisiting. But we haven't done a lot of integration of devices into any of our mobile programs yet for that reason. So we may, but I think that in having waited, we may have an opportunity to engage more sort of platform agnostic devices, and that will allow us to integrate data on the back end in ways that are in successful ways without going through proprietary solutions and everything. As far as apps versus platforms, I think the VA is trying to think bigger than just mobile applications, single mobile applications. Every VA, we want to have real patient-centered care. And a person with post-traumatic stress disorder, 80% of them have depression as well, but then they additionally have heart problems, they additionally have diabetes in an overwhelming number of cases. So if you look at a real veteran or any patient who's got an array of problems, you don't really want to make them use 10 different apps for their 10 different conditions that don't talk to each other, and then the provider can't see them all. So even just within the world of connecting apps, we have plenty of work to do in creating a platform to which all of those apps can connect. We were building a VA app store, but then we found out that Apple apparently owns the word store. So go figure. So now we're building an app library. Maybe Google owns that one, but. So the VA Enterprise Library provides the sort of that skinny waist, sort of similar to the open mHealth solution, where it deals with all the privacy and security issues there one time, so that all the apps can connect in and report back to the electronic health record in a meaningful way. With medical devices, we may have additional challenges there. In mental health, we're completely comfortable with self-report, even with all of its various challenges and drawbacks, and we'll happily put a person's self-report directly into their clinical record. Sometimes medical practitioners have a little bit more of a hard time with that. They don't necessarily want the person's their own glucose reading put directly into the record, as if a nurse or a doctor had done it. So there are some challenges that we foresee in the future, but hopefully we're building sort of more at the platform level than just at the app level.
Yeah, Kelvin, your perspective.
So I've got a question for my colleagues here. So we're talking about devices and apps. So do you think that in the future, what we call an app today could be a device tomorrow? Are the lines blurring between those? I mean, what do you see that going? Because when I look at some of the things, you can go to the Apple store and you can buy devices that you can connect to your iPhone that helps monitor various aspects of your health. And as this gets more and more sophisticated, one of the things that is very, very clear is we can't see around corners a lot of times as to where this is going. So is there a possibility that these apps could be something that needs to be regulated because of the kinds of things they connect to? Could they be devices tomorrow?
So is that a technology question, or is that a public policy question?
I think it's got aspects of both.
Carrie, let's make you conquer that one. Because you asked the question initially. So
I didn't ask that question.
And also, by the way, if anyone has a question, please come up to the mics and we'll get our questions going from the rest of you as well. But let's go back.
No, I think the answer, so technologically, there's a lot of companies that can already make these things happen. We don't want to have, nobody wants to walk around with 5 different devices or slapping 4 different smart Band-Aids on them to measure different things. These things can all be integrated. The reality is that today they are regulated, and what that converged device looks like in the future will depend on the guidance from the FDA. And as a matter of fact, we were hoping for it this month, but next year, early next year, hopefully, they'll put out their mobile medical apps guidance, where we'll actually get, a little more clarity around what's happening. And I'll just put in a plug for 5 o'clock tonight. Leaders from the FDA, FCC, and ONC are actually going to be upstairs to talk about what the policy environment looks like for next year.
What would be the title of that talk and the location of that talk, Carrie?
That would be in National Harbor, 12 and 13.
Thank you very much for that.
Yeah, federal policy update.
Okay. You have a question? Can you say your name and who you represent or who you are?
My name is David Dubbs, and I ran innovation for a Fortune 50 healthcare company. To your question, I think from the position of Apple, they would say that they are not interested in being a medical device. They don't mind, independent companies developing that technology that integrates with their system, but they just don't want to get into into the whole FDA issues and the regulatory and the liability and all of that stuff. So I just happen to know that for a fact. So cloud computing has been around for 20 years before Apple decided to get into iCloud, and it didn't come out of an ideation session or gee, we want to own that too, but actually as a function of solving a problem. So the number one problem at the Genius Bar, 50% of their interfaces with customers were people who had never synced their iPhone with their computer and saying, how do I do this? And so innovation for them always begins with a specific problem, and then they execute like hell. Although the Maps incident was probably a bad example of that. But in any event, I think that, Julie, you're spot on that people are throwing a lot of technology and solutions at the wall, and it remains to be seen whether this is sustainable over time. And no one really has the answer. There are a lot of companies that are chasing engagement, for example, and no one's quite sure if it's over the long haul can actually help you be healthier. And so I'm just sort of curious what you all are thinking about in terms when you are addressing some of these technological issues. Are you beginning from the problem, or are you looking more broadly? Because I think you can't start from, okay, we're going to solve obesity. It's boiling the ocean, and so I think the closer you get to the specific problem you're trying to solve is probably a better place to start.
Mr. Sorry, I'll rephrase the question a little bit, and we'll run the list and run the table. Actually, so, from where you sit, what is the big problem that you're trying to solve, and how do you see mobile as helping solve that? Chris, you're teed up once again with the tough question.
Thank you for your comments. I co-architected a large PHR for a large vendor who also said their PHR was never a PHR. And I think at the end of the day, that train has already left the station, that Apple, with all due respect, can not want to get into that space. But I think by virtue of the fact that you are all sitting here in this audience centered around mHealth, that it's going to be very hard to dissect what a device is. Is it the physical hardware, or is it the app, or is it both? And one of the analogy I would use is one of the biggest challenges the federal government has is adequately finding a definition of what an EHR actually is. When technology is moving far beyond the ability, these conceptual models of what we think an EHR is today. Those definitions, both technological and policy, are going to continue to elude us and probably drag well behind, as they do today, of the technology that gets deployed.
So are you saying that these companies it's like dating, where you're trying to have all the fun without any of the responsibility of commitment?
Yeah, I do, and that's exactly right, and that
Not that I endorse that behavior.
This company that will remain unnamed, that's exactly the thinking that we had when we were developing this isn't health data. It's not protected under HIPAA. And the reality of it was we ran headlong into that wall, which is why that PHR doesn't exist anymore, because the cost and risk that were associated with the data, which just happened to be health related, even if it was provided by the patient, really just started to kill the business model. The overhead associated with handling the health data was plenty to drive a stake through the heart of it.
So, Chris, you're president. So the hard question is where that line draws. Brian, what's the hard thing you're trying to solve?
That's a really good question. I think it's access to the data data just seems to be the word of the day. But our EHR is exposed internally And then it's accessible by our members on some digital channels, but it's the ability to push data back into that that's not already in there, right? So there's the very standard clinical data around your pharmacy or making your appointment or communicating with your doctor and your medical record. Then there's this ability to capture all of my personal health data that I can go do that on Microsoft Health Vault, but I can't combine those two together. That's a bigger problem that we're looking at, or a challenge, not necessarily a problem, but it's a challenge. I think that's giving that better view of that more 360-degree perspective of who you are and what your activities are. Back to the question that David had around, are we starting with a problem? We typically start looking at things from a problems perspective. I mean, my group has done a number of ideations and codathons this year where we actually started with first identifying what the challenges are and the problems that exist for whether they're clinician-based or member-based, and then seeing how mobile can perhaps solve that or address it, not necessarily be a silver bullet for it, but that's definitely a strategy that we follow of what's a challenge, can we clearly articulate it, and then how can mobile, for now, at least try to address it and resolve it or come to a different perspective on a solution. Julia?
Yes, we absolutely always start with a problem. So the problems that we have are insufficient care in various parts of the country where care is needed. We have providers that are overstretched and don't have enough time to spend with patients, where we need to optimize that care and outsource various parts of treatment if possible, and if we can do that in a meaningful and clinically ethical way. We have implementation challenges for our gold standard therapies. For example, the gold standard treatment for post-traumatic stress disorder requires you to bring a tape recorder to every session, and good luck to you finding a tape recorder in 2012. So if you have a device in your pocket that can do a recording, there's no reason not to alleviate that implementation challenge for getting the person the care that they need in the moment that they need it. We try to address the fact that we can't get people into care, as I said, for stigma and other logistical reasons, and for those reasons providing anonymous tools where possible that are something in the place of nothing, but still based on all of the science and clinical excellence that the VA brings to bear. And then finally, we want to create a patient-centered model where the patients really are. I mean, we've had models of this in the VA in the past. It's not that it's novel to mobile. Mobile just provides a new venue in which to do more of the same. We're providing tools to veterans to empower them to take control of their care and their communication with their providers so that they know what it is that they're communicating and what they can expect to get back.
So I would say from our vantage point, this is all about meeting individuals, whether they're patients or consumers, wherever they are, and about getting the care team, whoever that encompasses, the right information at the right time. And then a big question that we grapple with is, what is an appropriate regulatory framework for health IT in general? The way regulations work today, they really focus on analyzing things in silos as opposed to across the entire system. And we work in a complicated environment of systems, and we're just finding that the old frameworks aren't suited to the new way of delivering care and the technological innovation that is, proliferating.
Yeah, I'm going to approach this from a U.S. citizen perspective. I'm married to a lady that grew up in Sweden. So I get a chance to go to Sweden, a few times every year. And I can remember distinctly a couple of Christmases ago, we were in downtown Gothenburg, the second largest city in Sweden. And I looked around and something struck me. I didn't see, everybody looked fit. And I saw hundreds of people walking around downtown Gothenburg. I didn't see any obese people. And yet, Sweden is also a country where their mobile technologies and their mobile network is one of the most robust on the planet. So I think I look at this from what is technology really going to do for us? Is it going to help us be healthier? And I think we can all agree that one of the paradoxes we have with technology is it also causes us to be less active. Look at what the challenge that we have with our kids today. They're on iPhones and iPads and everything else. So which is it going to be for us? Is technology going to be an enabler for us to be more healthy or not? And I think that's my dream. I agree with all of my colleagues up here about, these devices and this capability should give us an ability to connect care to people in ways that we could never do it before. But we've got to fight that other side of it too, which is what technology also contributes to us not being as healthy as we can. So finally, I think this is all about, for me, it's all about what role does it play in behavioral change, in getting people and helping people to do what they need to do to make themselves healthier.
Great thoughts. Tell us who you are and why you're here.
My name is Eric Buffkin. I'm an entrepreneur in medical device with a little company called eTech. And Kelvin, I think you took the question right out of my head with your observation. Every one of us carries a mobile phone around. I mean, it's a great tool. It does many things, but it's a tool, just like a hammer or a saw or anything else. I was struck yesterday when I was on the escalator, riding up to my next meeting, and I looked around and there's probably 1,000 people on the escalator, and there's one person on the stairs. Amongst this crowd, where we're here for mHealth, that struck me. So I'd like to hear, and Julie, you made some interesting thoughts about tying, the motivation. I mean, we have a tool in our pocket. How are we tying that motivation? Who, in your observation, is doing the better jobs or the groundbreaking work to help tie that motivation to the data? And we got data falling out of our pockets. How are we tying that together? I'd be very interested to hear who's doing a good job or that maybe we've never heard about. And that's for everybody. I just picked on Julia because she mentioned it earlier.
We're okay with you picking on her.
I paid for my psychology license. I'll take the question. So I haven't seen a good example, is the truth, and that is my primary disappointment. I think I've been to maybe 4 or 5 of these conferences this year. Of everybody selling their product, and I haven't seen it, not even in some of the tools that are for psychological disorders. And I'm not saying, I mean, you can go to the App Store and you can see the stuff that I've worked on. I'm not saying that our stuff is perfect either, or even is coming close to what I think we need to ultimately achieve. There's a science. If I were an entrepreneur, what I would want to look into would be 2 things. Implementation science is number 1. I think it's accessible to business people. It's a jargony word that's something in the sort of family of marketing, so it's maybe not all that different as old wine in new bottles, but I would want to understand implementation science. And the second thing that I would want to understand is motivational interviewing or motivational enhancement. If a patient comes into my office and says, Doc, I want to go to the gym, I can't get myself to go to the gym, every day I tell myself to go to the gym or walk down the stairs when I'm at a conference, that person could want to do that for any number of reasons. The key to making that person actually do that is understanding why they want to do the exercise in the first place. Is it because his dad died at 42 of a heart attack and he doesn't want to die the same way? Is it because he is struggling in his marriage and his sex life is terrible and he thinks that maybe having more exercise is going to help that? Is it because he feels out of breath all the time and it's embarrassing to him? What is the specific as possible reason that this person wants to do this thing? And until you get at the core of that, if you're just saying, we as a society generally believe that eating a certain number of calories and walking a certain number of steps is a good thing, you're going to get nowhere, because everyone already knows that. And if that overall society, cultural level understanding was enough to make a difference, then we'd be Sweden and all walking around looking good, which isn't the case. No offense to anybody here. So that's it in a nutshell. I apologize if there happen to be any motivational enhancement experts in the room that I just offended with my gross overgeneralization. But at least if you could just take that piece and try to process what that would mean on an app, if it's personalization that's really the key to unlocking real change in behavior. I guess that's up to the innovators in the room. I'm just the guy with the doctorate.
Well, Julie, it's a related question of, we've had, lots of industries have kind of figured this out a bit. I mean, I fly in the same airline, I stay in the same hotel, and I'm shamed into exercising only because my exercise is broadcast to my friends who also, and Chris is working at it now. And I'm one of the guys on the stairs, and again, for me, it's out of shame, as my prime motivator. But there we go. But other industries have kind of sorted this out. Why has this been kind of slow getting into healthcare?
Or have,
I
we
think
are we
because we have
pretending?
the expert role, because I paid 6 years and $150,000 and then $410 every other year for my license. And I mean, you know, I don't know if you maintain your license because you're not practicing, or you don't know if you're practicing anymore, but it's a long road to hoe. And by the time we get there, we know that we're experts in what we're talking about. We don't necessarily believe that we need to do all the work of taking the patient with us and helping ourselves understand that we may be the experts on a kind of 30,000-foot level, but we're not more expert at your health care than you are. You are the expert on your own health conditions and on your own motivations, and that's the reality.
I think my personal story probably personifies the need. The need was, I didn't want to be on insulin, and I knew if I wanted to see my children grow up and have babies of their own, I needed to make a change. I needed to drop my A1C. As a clinician, I fully understood. And I made a lot of different excuses. I don't have enough time. I'm tired. All of those excuses. I had to do something. And it's those patients who have that internal motivation. Now, for the innovators in the room, I want you to build an app to where I can take a picture of what's on my plate, and I want the app to tell me what I can eat and what I can't eat based on my blood sugar at the time, or something like that.
Well, Chris, I have an app that just says, that's too much food.
Yeah, that's perfect.
So let's go to the question in the back.
Yeah, my name is Sang Kim. I'm a postdoc fellow at the NIH Clinical Center. I was very impressed by Dr. Julia Hoffman's demo of an app for PTSD yesterday. And I know we are talking about evidence-based protocols. But we usually talk about it in the scientific sense. So scientific evidence-based. But there are some components that are not that scientific, but empirically evidenced treatment, such as holistic or integrative medicine or even lifestyle medicine or mind-body approaches. Our technology is not there yet to prove what mind does to the body or what body does to the mind entirely. So my question to Dr. Hoffman is that, are you planning to add one section for like treatment of exploratory or experimental components? With some warning there, don't try.
We have a bunch of apps that are in development they're working their way through the new VA certification process right now for complementary and alternative medicine approaches to various problems, including mental and medical health problems. I don't know that we'll integrate it into PTSD Coach, because PTSD Coach has been downloaded over 100,000 times in 75 countries, and it's been versioned by about 10 countries at this point. So we need to be a little bit cautious about what we put into that tool. But certainly that's something that is valued in the VA and something that and in DOD as well, and something that we integrate into other tools. I think that the VA is going to be taking our mindfulness app and integrating some sort of sensing. I thought that they were talking about skin conductance, but but maybe it was heart rate. I'm not sure that they landed on, but we'll see. And if you send me an email, you have my card. If you send me an email, I'll be happy to send you an enterprise version of the app.
Thank you.
And also tell you that I was in Changsha, China not long ago, and the electronic health record in the hospitals there cover both Western and traditional medicine, completely comprehensive EHR across all types of medicine. Time for one last question.
Thank you. My name is Tyler Blitz. I'm from a company called Sweet Spot Diabetes Care. I'm curious, both at the VA and at Kaiser, how you see the role of mobile health moving forward in home health, telemedicine, especially to serve rural areas and populations, and also especially in supporting care for patients with various chronic conditions.
I can go ahead and start. I think I touched on that a little bit earlier with the 4 sites of care and home health being one of them, and mobile health being a real connector of that. We're doing some pilots in California and some other regions, especially with the devices of like, the iOS phones with the FaceTime, and actually being able to engage remotely, but actually having that visit together. I think, like I said, it's a real enabler of what's possible, so that you can actually engage with our patients on a regular basis. So, I mean, that's the immediate future that we're seeing, and actually piloting a lot of those things.
It's tricky. I don't mean to contradict something I said earlier about mobile being useful for rural populations, but I will say that there are significant connectivity problems, which I think have been touched on. So a veteran who's in, mountains in Montana, it may not have great cell service. So VA is using other means. So Movi is sort of a encrypted version of Skype. Again, I hope I didn't offend anybody. And we use all kinds of, and they have a Health Buddy tool, which is sort of it's just a true-false. You can answer true-false and monitor your health that way. So we have a couple of devices that are specifically for in-home care, and then we additionally have now a whole suite of mobile applications that are for caregivers, people who may require home service, less because of rurality and more because of inability to get to treatment themselves if they have more chronic conditions.
So we're just about out of time. In the last 30 seconds, with the holidays coming up, what is your wish for mHealth? Chris? 30 seconds for everybody. You got to fly.
Let's see. My wish for mHealth. My wish for mHealth would be to build applications that really do talk to each other in some meaningful way, and by meaningful, for the patient and the clinician.
Perfect. Brian?
Yeah, I'd agree with that. I think meaningful applications, there's way too many of them that are very, very repetitive and duplicative. I also think this concept around motivation is a huge one. And the ability, for me, motivation is oftentimes, what do I get out of it? So the reward and the feedback is something that I think is really important. I mean, we now have the ability to track, so what? Right? What's the reward and the motivating factor behind that? I think your example was great. I think it's really personal as well. So I think that's kind of my wish, to find out a way to make it rewarding.
Julia?
I guess for me, it's to spend the next year working with clinicians and identifying that patients aren't the only part of this mobile solution, to really work with even the old guard and bringing these things into care in a meaningful way, so that we can actually start using the tools that some of the patients are antsy to use.
I'll put the federal policy cap on and say that I would like to see the federal government be a consistent, reliable enabler of the mHealth ecosystem.
I think, in addition to everything my colleagues have said, I would like to see adoption to the extent that it really helps improve health and behavior. So nothing happens unless people use these applications to their own benefit. So I'd like to see that. I'd like to see a higher adoption curve.
Fantastic. I hope all of you get what you've asked for the holidays. Please join me in thanking the panelists for a great discussion.